Thank you very much. You hear me?
Sure, yeah.
Okay. Thank you very much to the organizers and to the chairs for this kind invitation. I'm very glad to be here. The topic, yes, is a hot topic. There are a lot of studies in this setting to define the role of immunotherapy for HCC in the context of liver transplant. This is my outline. Um, in the last 15 years, the median overall survival in HCC patients receiving a systemic therapy was increasing. You know, from SHARP trial with sorafenib, we had 10 months of median overall survival, then a little bit higher with lenvatinib, but no drugs showed a superiority to TKI until the last years with immunotherapy, and the last combination, ipilimumab and nivolumab, showed nearly 23 months of median overall survival. So these improvements is due probably to different features, like the use of sequential therapy. So HCC is like a chronic disease, probably. Patients are treated with different combinations of drug and can survive a long time. Also, the improvement of care of patients with chronic hepatitis, the treatment of portal hypertension complications, and so on. That is very important liver function to have a good, to have a systemic treatment. As you know, patients with decompensated liver disease cannot get the treatment. And then probably we, the oncologists, and we treat before earlier these patients. And this is another important point, because probably it's very important also before transplantation. These are the three combinations drugs approved, not just two approved and another one ongoing for approval. The first one, you know, atezolizumab, bevacizumab, then tremelimumab and durvalumab, and the last one, ipilimumab and nivolumab. And the combination, combining anti-PD-1 and PD-L1 plus VEGF in the first combination, or two different immunocheckpoint inhibitors, probably is the best strategy, because you know that HCC is a very tough tumor with different receptors, and the way of the tumor is a lot. So more combination, more drugs probably is the key features. Just to have a brief look of the first trial, you know, in Brave 150 is the first trial demonstrating the superiority of immunotherapy, atezolizumab, bevacizumab versus sorafenib in advanced HCC with a good liver function. And you know that the median overall survival was 19 in the arm with immunotherapy, and versus 13 in sorafenib group, with a significant difference also in PFS. The second one was the Himalaya study, tremelimumab plus durvalumab. These are both immunocheckpoint inhibitors, so with different safety profile, and for the first line therapy. Also, in this case, the STRIDE combination showed a superiority, 16 months of overall survival compared to 13 in sorafenib group. But the most important thing that in this trial, patient who responded to therapy with complete or partial response had at 4-year overall survival of 67%, never seen before. And the last trial was with nivolumab and ipilimumab with a prolonged overall survival higher, 24 months. And the most important thing that probably is important also in the context of translating in the context of liver transplant waiting list is the objective response rate in this trial was 36%, that is high, versus 13% in the TKI group. But we have also to take in account the safety. In these trials, the safety was not that bad, was comparable to TKI with different safety profile. In fact, we have to take in account, especially for combination of two immunocheckpoint inhibitors, the toxicity of immunomediated events like hepatitis and colitis as are more frequent. Also, the decompensation of liver disease that is, as said, very important in this setting. And for bevacizumab, it's important to monitor portal hypertension, related bleeding, proteinuria, and kidney function. But so this patient needs at least 6 months before the starting of therapy an upper GI endoscopy to avoid. But now we have different combinations, so probably those patients with high risk of bleeding or higher risk of perforation or so on can have different two immunocheckpoint inhibitors. And this is a very well done real world study. It is not in the context of transplant, but we have some message from this study. It's a real cohort of HCC patients treated with immunocheckpoints inhibitor compared to a cohort of cancer patients treated with the same drugs without HCC. And as expected, a patient with the HCC had higher risk of immune-related liver injury, probably, and for the presence of liver disease. But the important thing is that the immuno-related liver injury did not have a negative impact on the treatment outcome in HCC patients. And the overall survival was similar between patients with HCC who had or not adverse events. So it's a good message for our population of patients in waiting list. And also they saw that there was, in the majority of patients, the resolution of this complication related to the therapy, and also only 7% of patients had decompensation of the liver disease. So it's good, they are good results. For sure, we have to manage this patient in a multidisciplinary team. In this context, because immunotherapy can be used also with other therapies, with surgery, with radiological treatments, local regional, and so on. So it's very important nowadays to discuss these cases. So which is the position of immunotherapy in the context of liver transplant? Probably as we know, in the downstaging therapy or bridging therapy, we can use this therapy as alternative to other local regional or surgical therapies, or in combination with that. And so the population in waiting list that can benefit more to immunotherapy are patients who progressed beyond the liver transplant criteria, so who need downstaging, patients that are not eligible to other treatment for different reasons, or patients that are at high risk of dropout, so need bridging to transplant, or they are at high risk of recurrence of HCC. Probably this therapy, systemic, can reduce also the micrometastasis, so the risk of recurrence very early after transplantation. This is a proof of concept trial for patients in waiting list, because it's not for candidates of transplant. But this trial showed that immunotherapy can boost the efficacy of TACE. So these patients, also B7 patients, so a little bit decompensated, received durvalumab plus TACE, and then adjuvant to TACE also received durvalumab plus bevacizumab or placebo or durvalumab alone. So this treatment, combining treatment, can be a treatment used as new adjuvant therapy to transplant, because the results were very good. The PFS was significantly higher in the immunotherapy plus TACE arm, 15 months compared to 8. And the most important thing that is very important for waiting list patient, but more importantly, the time to progression, was 22 months in the arm group versus placebo plus this that was 10 months. So this is a message for the features because this combination could be very good for waiting list patient to avoid dropout. But at the beginning, many centers were reticent to use immunotherapy because the first report were very bad with patient with a poor prognosis. Clinical trials are very difficult. There are some ongoing, but it's difficult to run for the diversity of population, for the different time to transplant, and so on. Nevertheless, a number of centers have explored yet the use of immunotherapy before transplantation. This is the first report, very bad prognosis. Patient died early after transplant for an acute hepatic necrosis. He received the last dose very, very close to the transplant. We don't know, but we'll see that the washout period is very important. And this is the first small series reported with positive results from Mount Sinai. These 9 patients had a very good outcome in terms of survival, rejection, no rejection cases, and also in terms of tumor necrosis, because 1/3 of these patients had more than 90% of tumor necrosis. And then there was a lot of more studies. This is a systematic review, including all studies in which patients received immuno checkpoint inhibitors before transplantation. And they selected 91 HCC cases in 30 studies, and 26% of patients developed rejection. Is like the data proposed and reported before. 9 patients, 9.9% had HCC recurrence, and 9 patients, 9.9% died. So the rejection was in the first 2 weeks after transplantation. And we know from some studies that the drug that is at higher risk is a PD-L1 inhibitor, because he binds also B7-1, another checkpoint, and the lower risk is using CTLA-4 inhibitor. And in this review, in this meta-analysis, they show that the older age and the longer washout period reduced the risk of rejection. So those patients with a washout period more than 90 days had lower risk of rejection. We know that from pharmacokinetic studies, because we know that the half-life of these drugs is important, but it's just 13 to 25 days. But it's not the only thing to consider. Another important point is that these drugs have a high affinity to their targets, and the occupancy of receptors it seems to decline around 3 months after the last dose. So it's very important to notice this point, because probably is the most important risk factor. And a good news is that over 80% of rejection was resolved. So it's a very good news. And another important point is that patients who experienced rejection had the same survival compared to patients without. And this is the results from Plenty trial. Is a trial including patients who received pembrolizumab and lenvatinib, only 22 patients, 11 in the Plenty group. And also here, the recurrence-free survival was significantly higher in patient treated, 37% at 30 months compared to 12. And also the objective response rate in the Plenty group was very, very good. 60% of patients had also a very good response to immunotherapy in the explant pathology, and no rejection cases, But I have to say that a graft versus host liver disease leading to death of one patient, they said not related, but probably related to immunotherapy occurred. So what we have to consider, for sure, in patient that we think to be candidate for immunotherapy during the waiting list, we have to consider the potential toxicity. We saw that it could be good in terms of hepatic decompensation and toxicity. Obviously, the patient should be managed and monitoring very strictly. The risk of rejection is here, 20-25%. And we also have to consider that there are other treatments. So probably we have to choose and select very well the patient. Another point that we saw that the combination of immunocheckpoint with other local regional are very good and could enhance the response to treatment, and also that the graft loss is rare. There are not a lot of cases. So finally, probably in the future, we have to personalize the risk and the benefit to use the drugs before transplantation, considering all these features of the tumor and also of the patient. And it's the trials that are ongoing and probably will give us the answers. What about post-transplant? Very briefly, this is the first report of the use of immunocheckpoint inhibitors after transplantation for an HCC recurrence, and was a bad report because this woman died very early after transplant for a severe rejection and necrosis of the graft. This is a systematic review published in Hepatoma Research in 2021, 28 patients including, and 32% of them had rejection. 44 responded to immunosuppression, so resolved the rejection, but 3 cases of graft failure occurred, more in younger patients. So another time, the age is important, probably because you know that there is the tolerance after transplantation in the long term, and also the short period after transplant is an important feature to consider. This is other studies in the post-transplant use of immunotherapies, also in other organs, in other solid organs. And as you see, the rate of rejection is 25 up to 50%. And there are some data, but just proof of concept, that some markers, this is a study, just 5 patients, but some markers like PD-L1 expression in this patient may be a marker for rejection, but we don't know, we need more data. And this is the last meta-analysis, including 52 patients treated after transplantation, not only for HCC recurrence, but also for other de novo tumor. You know that this is one of the most important causes of morbidity and mortality after transplantation. And they had, again, 30% of risk of rejection. The bad side of the results is that have an impact on survival after transplant, as well as the response to immunotherapy had an impact as expected for the progression of tumor after transplantation. So in conclusion, immunotherapy is a promising method and option of downstaging and bridging before transplant, probably in combination with other therapies, local regional or surgical. The main concern is rejection, but it seems that it doesn't impact on survival after transplant. And the toxicity also is important. We saw from some studies that in cirrhotic patient compensated, probably the toxicity is manageable, but we'll see in the next future. And the important point is that we have to respect a washout period. That probably should be at least 8 weeks let's say probably 12 weeks. And after transplantation for HCC recurrence or for other de novo tumors, we can probably wait more time and more data, or decide case by case, considering the time, the age of patient, considering the time from transplant, and more collaborations or multi-center study for sure will be needed in the next futures. Thank you very much.
Thanks a lot, Martina. Really informative, a lot of new pieces of information. And this is, again, is open for discussion. For sure, Giuliano will have a number of issues.
No, thank you. Thank you. A lot of material you presented. It's really amazing how many drugs have been introduced. I just have a question. You presented pharmacokinetics, and you said that there is a demonstration that the antibodies, which can stay there for 13 days, they bind to their specific targets.
Yes.
You know which targets you mean?
Yeah, the immunocheckpoint inhibitors bind normally the normally present in our immune system, the checkpoint inhibitors, PD-1, PD-L1, CTL4, that is the main target. And normally these molecules inhibit the overexpression of Tregs. So these drugs bind these inhibitors, and so the tumor have an immunosuppression. And so the problem is that this binding is over the half-life of the drug, so can persist until 3 months. I don't know if
I have difficult to hear you, but I believe that PD-1 and PD-L1 are distributed also on macrophages, on immune cells around the body.
Yeah,
so
sure.
It's not, it doesn't bind only to the immune cells present in the tumor microenvironment, but it also binds to cells. In fact, this is the way you can explain the side effects, because
sure.
Some of these antibodies just activate, the macrophages. And, this is probably also the reason for the rejection reaction when you use that after transplantation. And
Yeah.
I also would not use the word necrosis, because that's not happens. You do see maybe apoptosis, but if you get necrosis, then you would see the markers in the blood. If the theory would be right that you activate immune reaction against the tumor, then you would have tumorolysis, and this is, it should be, you could see LDH in the serum or something like that. That's what you're looking for. You're looking for marker of response. And if you would induce necrosis by your antibody, but that does not happen. You don't have necrosis, but if you do histology, you would not see necrotic cells, but you wouldn't see cells at all.
Yeah.
Okay, and that's a question of how do you think about the mechanism of work, how these antibodies work, Okay.
Yeah, sure.
That's it.
Thanks a lot for this fascinating insight in the pathophysiology and mechanism. But let's take it a little bit more practical and go into clinics. Martina, if you have a patient with, let's say, well-compensated liver cirrhosis and 10 nodules and very high alpha fetoprotein, would you consider, of course, I think, a systemic therapy according to the protocol, one of the protocol you presented? But this is supposed to be done in the context of a liver transplantation setting, with a potential implication again for downstaging and inclusion on the waiting list. Or you think that any setting may be managing these patients?
No, for sure. You know what I think, but for sure, I think that this patient should be referred to a transplant center. I mean, they can receive systemic treatment to get a downstaging to transplant. That is the best treatment also for the liver disease. And I think that even if they achieve a complete response, probably this patient should be transplanted. Not only because there is a liver disease, but also because we don't know very well yet if there is a complete radiological response or not. Like in the explant pathology could be different result. So I think that for sure this patient should be referred.
No, that's clear, and thanks. It is even more complicated. But you know what I see in my outpatient clinic, unfortunately, more and more are patients that are going to systemic therapy. They receive a good, you said about 38% of the patient, 40% has an objective response, but then they still ongoing on therapy and they are not referred to any potential scale up in terms of hierarchy of the therapy. That's an issue.
Yeah.
And there is probably an issue which is related on the lack of interaction between the pathological world and the oncological world. This is something that politically worldwide we should face. And I don't know what you think about it.
Yeah, educational programs probably. And can I add something about a biopsy? Because it's true that we have to take in account the safety of patient. But in this context, with these drugs, we don't know very well which patients respond to one drug or another. Probably if we can, we should do the biopsy also for markers for rejection or for sure for the response to do the treatment. So I think that a sensibilization also for biopsy is important when we can.